Hello and welcome to the June edition of ISGyP Live Journal Club. I'm your host and moderator for this session. My name's Talia and I'm very excited to be presenting live for the first time ever from Melbourne, Australia. Before I begin, I want to thank Natalie Benet for inviting me to join her in hosting this journal club and for her amazing support in the lead up to today. She is a superb mentor. I know this firsthand, and she's definitely one of my favourite people in pathology. Natalie is online with me now, making sure that we don't have too many technical glitches. Thank you, Natalie, for being here. I know it's very late in the day for you and well past your bedtime. Now, while attendees are still joining, I'm going to start with some general housekeeping. Next slide, please. Thank you. Okay, so the plan going forward is that I will present Journal Club alternate monthly with Dr. Benet. So this means that every other month, Journal Club will occur at a time that suits those of us in the eastern half of the world. So obviously presenting at this time in Australia is late in the day in the US and in the middle of the night in Europe. However, if you register for this event via the ISGyP educational website, you will be sent a video link to watch the recording afterwards. And our hope is that by alternating in this way, we can make Journal Club accessible to anyone around the world who might like to listen. And we obviously would like to attract presenters for whom the Australian time zone is more favourable. So to that end, if you live in any of the countries in the eastern half of the world and you're an early career pathologist or a trainee and you'd like to participate, please contact either Dr. Benet or myself at the email addresses down here. Now, we'll provide you with a journal article, we'll mentor you in the lead up to the session, including running a practice session presenting so that it's hopefully not such a daunting experience on the day. And you don't have to be an ISGyP member to participate. And a reminder that ISGyP membership is free to all trainees. You can find out more by visiting the ISGyP website where all of the ISGyP Live educational events are also listed. Next slide, please. Okay, here are the learning objectives for Journal Club. And as you can see, the main aim is to engage junior and trainee pathologists and to provide mentorship. If I could have the next slide. So this is what we'll provide you in the lead up to presenting. This is a template for presenting the papers. And it's also, I think, a really good guide for critically evaluating the literature and writing journal articles yourself in practice. And now on to the schedule for today. So we have 3 presenters today who are going to present in this order. And at the end, we'll have some time, hopefully, to wrap up, take questions. We'll also have some polling questions for you, the audience, to answer following each presentation. Next slide, just quickly, for those who are new to Zoom, the Q&A button is down the bottom of your screen. You can click there to post a question, and you can also upvote any question you would like answered using the thumbs up sign. And also at the end of the presentation, a survey will pop up and we'd appreciate you taking the time to fill this out so that we can continue to improve this event. All right, so on to this month's theme, which is uterine cervix. Now, our 3 speakers today, we have Dr. Vanessa De Villa-Atienza from the Philippines. She's presenting NTRK fusion cervical sarcoma, a report of 3 cases emphasising morphological and immunohistochemical distinction from other uterine sarcomas, including adenosarcoma, published in Histopathology in 2020. Next is Dr. Sadeq Islam from the USA. He's presenting HPV-negative tumors in a Swedish cohort of cervical cancer, published in the International Journal of Gynecology in 2020. And our last speaker is Dr. Neslihan Kayraklioglu from the USA, presenting Invasive Stratified Mucin-producing Carcinoma of the Cervix, a study on morphologic diversity, published in American Journal of Surgical Pathology in 2020. So I'll now introduce our speakers. First, Dr. Vanessa De Villa-Atienza. She's an anatomical and clinical pathologist in subspecialty breast and gynecological pathology practice, both as hospital faculty and in private practice in no fewer than 4 separate workplaces north of Manila in the Philippines. Our second speaker is Dr. Sadeq Islam, who is a PGY3 pathology trainee at the Warren Alpert Medical School of Brown University in Providence, Rhode Island. And our third speaker, Dr. Neslihan Kayraklioglu. She's a PGY2 pathology trainee and also has a PhD, and she's at the University of California, San Francisco. Okay, so without further ado, we'll move on to Vanessa. Vanessa, if you'd like to share your screen, I'll mute myself.
So hello everyone, I'm NASA's Dr. Talia so kindly introduced. And before I start, I would like to thank ISGyP and Drs. Banay and Talia for their efforts in organizing this educational event and for encouraging participation from across the globe. I'm grateful for the opportunity to be part of today's activity. I will be presenting an article by Dr. Joseph Rabban and colleagues on NTRK fusion cervical sarcomas with the title here as Dr. Talia already mentioned earlier. And this was published in the Journal of Histopathology in January last year. Before we go to the gist of the study, first, what is NTRK? NTRK stands for neurotrophic tyrosine kinase receptor, and there are 3 NTRK genes which code for corresponding tyrosine receptor kinases, which normally function in central and peripheral nervous system development and activity. When fused with other genes, they cause activation and overexpression of TRK protein, which can be detected by pan-TRK immunohistochemistry. And these gene rearrangements may promote cellular proliferation and survival, thereby imparting oncogenic potential. Identifying such tumors with NTRK fusion is clinically relevant because targeted therapy in the form of NTRK inhibitors, such as larotrectinib, have been shown to be quite effective for advanced stage and recurrent tumors. These mutations have been reported in many tumors at various sites, most notably infantile fibrosarcoma, congenital mesoblastic nephroma, and secretory carcinoma of the breast and salivary gland. And recently, it has also been reported in the uterus. At the time of writing this study, 13 cases of this new entity had been reported in literature, majority of which arise in the cervix of young women, showed unusual fibrosarcoma-like morphology, and expressed S100 and pan-TRK, but not Desmin ER and PR. So the aim of this study was to expand the morphologic spectrum of this tumor by reporting 3 additional cases that showed adenosarcoma-like features, which were not described in previous reports. And since adenosarcomas were in the main differential, they compared the IHC patterns and investigated on the presence of NTRK mutations in adenosarcomas as well. With this, they were able to come up with practical recommendations for the diagnostic workup of such unusual cervical neoplasms. For the methods, 3 cases of cervical sarcoma with focal patterns reminiscent of uterine adenosarcoma with stromal overgrowth were included in the study. These patterns, as listed here, would make you wonder about an adenosarcoma, especially in the absence of distinctive features of any other specific tumor type. They, however, did not meet the classic criteria for adenosarcoma. Clinical information was obtained from the UCSF electronic medical records. All slides were reviewed, and an extensive immunohistochemistry panel was performed, including pan-TRK and S100, as well as additional antibodies to evaluate the broad differential diagnosis of uterine mesenchymal tumors, including smooth muscle differentiation, rhabdomyosarcomatous differentiation, endometrial stromal differentiation, picomas, IMTs, uterus, melanoma, MPNST, sarcomatoid carcinoma, and others. DNA sequencing was performed on all 3 tumors using multi-gene panels that included all 3 of the NTRK genes. A comparison set of 19 uterine adenosarcomas that had been previously characterized were re-evaluated for NTRK rearrangements, and 14 cases which had sufficient tissue were stained with pan-TRK and S100. For the results, with regards to the clinical features of the cases, the patients were relatively young at 24, 30, and 49 years old. 2 presented with vaginal bleeding. 2 patients had an endocervical polyp and underwent polypectomy, while the other patient had an endocervical mass which was biopsied. Imaging in 2 patients confirmed that the tumor was confined to the cervix. The initial diagnosis for all patients was a mesenchymal tumor of uncertain histologic type with a differential of an unusual variant of adenosarcoma with stromal overgrowth. A high-grade ESS or undifferentiated sarcoma was also considered in 1 patient, while a typical smooth muscle tumor was a differential in another patient. 2 patients opted for surgery with no dissection, while the other patient had no further surgical management. On pathologic examination, the tumors were 15 and 47 millimeters, confined to the cervix with no lymph node mets. However, 1 had lymphovascular space invasion. 2 patients had no further treatment and were disease-free at 6 and 19 months, while the patient with LVSI underwent adjuvant chemo and radiation. She developed pleural mets after 16 months, and it was at this time that the tumor was subjected to genetic testing for possible actionable mutations, and a SPEC-C1L NTRK3 rearrangement was found. She was then given larotrectinib, and there was no radiologic evidence of residual tumor 15 months after treatment. This shows MRI images from 1 patient, and we can see the polypoid mass in the cervix with a thinned cervical stroma suggesting invasion. This gross photo shows the uterus of the same patient following polypectomy. We see that there is a residual polypoid mass in the endocervix with stromal invasion. This shows a coronal slice from the same case. On gross, the tumor is ill-defined, and this nicely correlates with the microscopic appearance. The tumor is confined to the transformation zone and endocervix and shows this polypoid growth at the mucosal surface with an irregular infiltrative border. This is highlighted by S100 and pan-Trk immunostaining. These photomicrographs show the polypoid mucosal surfaces of the tumors with contours that are similar to those of adenosarcoma. The tumor cells also entrap benign endocervical glands with interglandular stromal projections, further raising the concern for adenosarcoma. However, in contrast, tumor cellularity is uniform and there is no periglandular stromal condensation seen. Again, we see here the uniform high cellularity of the tumors. The tumor cells are arranged in somewhat intersecting fascicles and may resemble smooth muscle neoplasms. Nuclear atypia is mild to moderate, and mitotic activity is highly variable, with 0 per 10 high power fields in 1 tumor and up to 18 to 20 in the other tumors. Rare atypical mitoses were present. 1 tumor showed foci of enlarged irregular nuclei with intranuclear vacuoles. And although not distinct in these photomicrographs, a mild lymphocytic infiltrate was present, mostly near the mucosal surface. And pertinent negatives were the absence of desmoplastic stroma, necrosis, and heterologous elements in all of the tumors. The tumor borders were ill-defined, ranging from mildly irregular contours to infiltrative tongues and nests in the outer half of the cervical wall and surrounding these large caliber vessels. With regards to the IHC phenotype, let's go back to this list of IHCs that they did. All 3 tumors were positive for pan-Trk with moderate to strong staining intensity in 2 tumors and weaker intensity in 1 tumor. S100 was strongly positive in all 3 tumors, and some cases showed negligible, less than 5% positive staining in some of the markers, including CD10, cyclin D1, BCOR, and ER. H3K27M3, P53, and RB were normal, and the rest of the stains were all negative. This shows the schematic of the NTRK gene fusion in the 2 patients that I haven't mentioned. One had a TPR-NTRK1 rearrangement, while the other had a TPM3-NTRK1 rearrangement. In comparison, all 19 cases of uterine adenosarcoma were negative for NTRK gene mutations, and all cases tested were negative for pan-Trk and S100. So in summary, the study presented 3 cases of NTRK fusion cervical sarcoma, highlighting their potential to be misclassified as uterine adenosarcomas. However, this study showed that adenosarcomas with classic morphology are not variants because they do not have NTRK rearrangements and they don't show S100 or pan-Trk staining. These tumors can also be misclassified as other uterine mesenchymal tumors, such as uterine IMTs, because of the presence of the lymphocytic infiltrates. In contrast, majority of IMTs are in the uterine body, and the infiltrates also usually include plasma cells. Leiomyosarcoma was a common diagnosis originally assigned to cases which were subsequently confirmed to be NTRK fusion sarcomas. These tumors, however, are not expected to have strong diffuse S100 staining. However, caution is advised in the use of pan-Trk without the concurrent use of S100 because rare examples of leiomyosarcomas may be positive. In a study of 97 cases, 2 cases showed strong diffuse pan-Trk staining. However, all of these cases were negative for S100 and NTRK rearrangements on fish. High-grade ESS is also a differential because some of the NTRK fusion sarcomas, as we saw, may show moderate nuclear atypia and increased mitotic activity coupled with a high tumor cellularity. Cyclin D1, CD117, and BCOR are usually positive, and in comparison, BCOR was negative in majority of NTRK fusion sarcomas with only rare tumor cells being positive in some cases. However, I'd like to point out another pitfall in the use of pan-Trk staining, which was shown in more recent studies, where 16 out of 17 cases of high-grade ESS with BCOR genetic alterations were shown to be positive for pan-Trk. However, ESS would be expected to be negative for S100 as well. Collectively, the findings in this study and 2 other series demonstrated that in the absence of smooth muscle and endometrial stromal phenotype, NTRK fusion sarcoma should be considered. They suggest that these neoplasms be subjected to S100 as a screening tool, and diffuse strong staining should prompt further workup with pan-Trk staining. And if this gives a positive result, proceed to molecular testing for NTRK rearrangement that will confirm the diagnosis. Again, diagnostic distinction of these sarcomas is clinically relevant for 2 reasons. The first is that a subset may behave quite aggressively despite low stage and lack of severe morphological pleomorphism, and targeted therapy is an option. I think that one of the strengths of the study is that they were able to present 3 cases with almost complete data, and it would be interesting to know how these patients are doing around 1.5 years after the study was published. Majority of their findings align with the data in previous reports, and by describing a new potential pitfall, they were able to expand the morphologic spectrum of NTRK tumors. Since this is a relatively new entity, the extensive immuno and morphologic comparison that they did is very useful in highlighting how NTRK tumors are different from other uterine mesenchymal lesions. And another strength is that they already had adenosarcoma cases from a previous study that allowed them to differentiate between the two, both on an IHC and a molecular level. And finally, they were able to further emphasize the clinical impact of diagnosing such tumors by describing the first patient with an NTRK cervical sarcoma who responded well to targeted therapy. Given that they presented 3 additional cases, it would be nice to see if the proposed diagnostic algorithm will hold up as more cases are reported. And another limitation is that the algorithm is heavily reliant on IHCs and would be difficult to adapt in settings such as ours, where immunohistochemistry is not widely available and can be cost prohibitive for majority of our patients. NTRK tumor testing and targeted therapy are also not yet readily available in our country, but the morphologic features that they presented in the study will be very helpful in at least making us aware of this new entity. And the suggested algorithm provided some good pointers of when we should consider NTRK cervical sarcomas as part of our differential, and maybe we can at least push for an S100, which is available in some of the laboratories here. Clinicians and patients can also be counseled about this new entity, especially if the patient is a young woman with cervical sarcoma, because of the possibility that it may recur or spread, at which time confirmatory diagnosis may be done because targeted therapy is an option. And with that, I would like to thank you for your kind attention. I'm happy to take any questions if there are any.
Oh, thank you. I think right now what we're going to do is launch the polling questions for the audience. So I will put those up on the screen and Dr. Talia will take over. And I will also put them up for those watching the video.
While everyone's looking at the questions, I'm just going to say thank you, Vanessa. That was a masterclass in how to distill a very detailed paper down into an incredibly easy to follow PowerPoint presentation. I'm in awe of your PowerPoint skills. well done. Okay, so here's our two questions. Looks like the first question was an easy answer for people.
I usually try not to make them so challenging that it would take too long to read them. So yes, I just want to make sure people, but yes. We'll give about 15 to 20 more seconds and then we'll end the poll and share the results with everyone. Okay, so I'll go ahead and end the poll and I'm sharing the results so everyone should be able to see them.
Okay, so everyone did really well on the first question. 92% of participants answered that correctly. So which of the following histologic features were present in all three cases examined? And that is highly cellular intersecting fascicles of spindled cells and not these other features listed here. It looks like question 2 is a harder one. We've got quite a split of answers. The target response was both A and C. A subset of NTRK fusion sarcomas may behave aggressively despite low stage and morphology. And C, targeted therapy with tyrosine kinase inhibitors may be an effective option. So both of those things are correct. The diagnosis of either an NTRK fusion sarcoma or adenosarcoma doesn't require referral to a genetic counsellor. We're not aware of any hereditary syndrome in association with NTRK fusion sarcomas. So this is the correct answer, both A and C. But there was quite an even split across all 4 responses, 5 responses amongst the audience.
I think maybe it was a badly written question. We can blame that one on me. You do have one item in the chat telling you that you did an excellent job on your presentation. And just a reminder, folks can throw things in the Q&A and we can come back to this at the end if we want. Okay. All right. So
All right, Sadeq, if you're ready.
Yeah.
Yes, I am.
Thank
Let
you.
me share my
I'll just
screen. You can see my screen, right?
Yes,
hello and
that
welcome
looks
to my,
great.
Oh, sorry. Hello and welcome to my presentation. My name is Sadeq Islam. I'm one of the third-year pathology resident at Brown University program. I'm going to present this interesting article titled HPV-negative tumors in a Swedish cohort of cervical cancer. This article was published by Kaliff M and friends from Örebro University, Sweden, and it was published in the International Journal of Gynecological Pathology in 2019. Before going into detail of the article, I would briefly discuss about HPV association in cervical cancer. As we know that cervical cancer can both be HPV associated and HPV independent. Though majority of the cases are HPV associated, namely the squamous cell carcinoma, usual type of adenocarcinoma, and other epithelial carcinoma, about 15% of the cervical cancer can be HPV independent, which are more commonly the special type of adenocarcinomas like the gastric type, mesonephric type, clear cell type, and about 5 to 7% of the squamous cell carcinomas are HPV negative. This study was done based on the fact that recent advances in detecting HPV DNA by better PCR method has shifted many of the institutions from doing a cervical cytology based method to a HPV detection method for screening of the cervical cancer. But because of this presence of a large number of HPV negative cervical cancers, the question has been raised that whether this shift could lead to missing some of these HPV negative cancers. So this study reinvestigates the HPV negative cervical cancers to increase understanding of the true HPV negative fractions of cervical cancers, their histologic pattern and clinical behavior, and came to the conclusion that implementation of the HPV-based screening for cervical cancer has limited potential risk for missing extremely rare HPV negative cervical cancers. So this study employed 37 HPV negative cases from a pool of 209 invasive cervical cancers, which were diagnosed between 1992 to 2004 in 3 institutions of Sweden. And these 37 cases were initially diagnosed as HPV negative by PCR method. And these samples were subsequently tested for HPV in 3 subsequent steps of using different PCR method, followed by look into by a pathologist to reclassify the histologic pattern and immunohistochemical pattern of these tumors. In following slides, I will go a little bit detail about the steps. In step 1, the HPV negative or invalid results from the previous genotypes, naming during the initial diagnosis, were included in this study. And this step used the same PCR technique, which is the Aniplex-2, which is a real-time PCR, which targets about 28 HPV genotypes. And it targets the viral L1 gene together with the human beta globin gene. And it does a melting curve analysis at the end of 30, 40, and 50 cycles when it reheats the DNA to separate the strands, which gives the fluorophore. And by detecting them, a semi-quantitative demonstration of positive result is done. In step 2, the negative or invalid results from step 1 were included. In this step, viral E6 and E7 genes were targeted along with human ACTB gene. And this technique targets about 12 high-risk HPV and 2 low-risk HPV genotypes. This PCR curve was manually assessed at the end of 35 cycle for positive results. And in step 3, the samples which were constantly negative, and in step 1 and step 2, alternate tissue block were used to take DNA samples, and they were examined by using the viral L1 and E6, E7 gene to demonstrate the HPV positivity or negativity. And lastly, all the cases which remained negative, which were 30 out of the 37 cases, were examined by a pathologist and reclassified according to most recent WHO classification. And also immunohistochemistry tests were done to confirm squamous differentiation, and also immunoreactivity to P16 and P53 were looked into. In addition to all these 4 steps, and second general method of detecting viral L1 together with human MGP5 or 6' primer system were used to look into the discrepancy that was found between the initial HPV status during the diagnosis versus the PCR tests that were done during this test. As some of the previous studies has demonstrated that this viral N1 gene can degrade when tissues are stored for a longer time. But this testing on L1 did not show any difference between the initial test versus the secondary general method. So this table from the left side is taken from the paper itself. As you can see that the HPV negative cases were present at an older age, and more commonly they were adenocarcinoma. And both HPV positive and HPV negative cases, they were present at an early stage, mostly FIGO stage 1 and stage 2. And the HPV negative cases did worse in terms of cure rate, overall recurrence, and survivability. Another interesting finding, if you see on the HPV negative side, that the cases which were older than 2 decades were the majority of the negativity following the subsequent investigation in this article. So following all this step, out of those initial 37 cases, we only found that 14 of these cases remained HPV negative, and 16 were reclassified into different HPV positive, indicating that there is a high percentage of false HPV negativity in those HPV negative cases. So this study demonstrated that HPV negative proportion is actually reduced from initial study of 14% to 7%. And most remaining HPV negative tumors were adenocarcinoma, which we can see when we see the chart that it's kind of similar with what it was before. And among these HPV negative, when they were stained with P16, majority of them were positive for P16, which is 9 out of 14 cases, indicating that there is still a large number of HPV false negative cases among these negative cases. And this false negativity is most likely a result of long-term storage and methodical limitation, or also could be some unknown type of HPV which we cannot detect yet. So this study advocated that HPV negative adenocarcinoma precursors or adenocarcinoma should not be a reason for hesitation for advocating HPV screening in cervical cancer prevention. Thorough methodical approach with multi-step analysis using different PCR technique targeting different viral genes, taking consideration of previously described pitfalls of HPV detection method, and histologic review and morphologic reclassifications are the strength of this study. There are areas of improvement, including making the sample size large and also including multiple racial consideration and regional consideration for HPV positivity and negativity, and also not including cases older than 2 decades, as this study have demonstrated that cases which are older than 2 decades shows most of the negativity, which might be secondary to DNA degradation due to the storage. So based upon this study, the HPV testing can be used as a primary screening method for cervical cancer and precursors, particularly in younger population under the age of 30. Thank you very much for your attention. I'm ready to take questions.
Okay, if you don't mind stopping to share, and I will launch the polling questions. Oops. Okay, these are out of order. There we go.
No one's voting.
I think maybe the question stems are a little long. Takes a moment.
There we go.
Okay, we'll give a little bit more time. Okay, and now I will share the results with everyone and highlight the correct answers for those watching the video.
Okay, so 80% of respondents were correct with question 1, which of the following is true regarding HPV-negative carcinomas of the uterine cervix. These tumours are more likely to be adenocarcinomas. And with question 2, 70% of respondents were correct that of the originally negative tumours which were sampled, which of the following is true? The additional HPV positive cases were more likely to be squamous cell carcinoma. So well done. And Sadeq, well done. That was a very technical paper, quite daunting to tackle, and I thought you distilled it down really nicely into easy to follow points.
Yeah.
Thank you.
Yes. Okay, so we can have. Are you ready?
Well, yes, I'm starting my share. Okay, you can see it now, right?
Yep, looks great. Thank you.
Okay, hello everyone. I'm Neslihan Kayraklioglu from University of California, San Francisco. And where is it now? Okay, I'm going to talk about this paper titled Invasive Stratified Mucin-producing Carcinoma of the Cervix, a study on morphologic diversity. And this was published in July 2020 at the American Journal of Surgical Pathology. And when we look at the other lists, we see contribution from expert pathologists from different institutions. So this is a multi-central international case series. So before talking about the invasive stratified mucinous carcinoma, I would like to start with its precursor lesion, which is stratified mucin-producing intraepithelial lesion, or SMILE. So this is an HPV-associated lesion, and this is actually a subtype of endocervical adenocarcinoma in situ, even though we don't see well-formed gland formation. So the lesion shows these stratified immature epithelial cells with nuclear ATP, nuclear hyperchromasia, with intracytoplasmic mucin seen throughout the lesion. And then today's topic, the invasive cervical mucinous carcinoma, or ISMC, looks similar to its precursor lesion SMILE, with this stratified mucin usually forms these nests invading through the stroma with this peripheral nuclear palisading. However, this is not the only morphology of the ISMC. These lesions show phenotypic plasticity, and they can mimic other tumors. So as we know, the endocervical adenocarcinomas are now divided in two groups, HPV-associated and non-HPV-associated. And there's a significant difference in prognosis of the two groups. The HPV-associated endocervical adenocarcinomas have a better outcome. However, when we look at the subtypes of the HPV-associated group, we see that the ISMC has the worst prognosis, and they usually present with larger tumor size, pelvic lymph node involvement, and poor prognosis. So given the importance of the diagnostic accuracy in recognizing this potentially aggressive entity, authors aim to better characterize the morphologic spectrum of ISMC and its association with other histiotypes. So they identified 52 cases from 10 institutions, and after a consensus diagnosis, they classified these tumors according to the amount of ISMC component the tumor have. So if the ISMC component is larger than 90%, they classified those tumors as pure ISMCs. And if the ISMC component is less than 90% and more than 10%, these tumors are categorized as ISMC mixed. And in these mixed tumors, the other histiotypes included usual endocervical adenocarcinomas, adenosquamous carcinomas, mucinous carcinomas, and neuroendocrine carcinomas. And the tumors with less than 10% of ISMC components were excluded from the study. So they evaluated the architectural and cytological features, their association with the precursor lesions, the FIGO stage, and the status of lymph node metastasis, as well as the Silva patterns of invasion, which is rather a recent parameter that we starting to use to classify invasion patterns in endocervical adenocarcinomas. So the pattern A has the well-demarcated glands with no destructive stromal invasion and has the best outcome, and pattern C as the diffuse destructive stromal invasion and associated with the worst clinical outcome. So the results show 75% of the patients were younger than 50 years old with a mean age of 40, and 30% of the cases were FIGO stage 2 or higher. And 92% of the cases showed the worst invasion pattern, the Silva pattern C. And 1/3 of patients presented with lymph node metastases, and 29 cases were associated with a precursor lesion, either a SMILE, HSIL, AIS, or a combination of these. So the typical appearance of ISMC is shown in this slide. So the amount of mucin can vary. As seen here on the left, we have a mucin-rich ISMC, and on the right, we have a mucin-poor version. But the morphology is similar. So these are composed of these nests of stratified mucinous cells with round, slightly irregular nuclei with no prominent nucleoli, and we see this characteristic peripheral nuclear palisading at the edge of these nests. And like the other HPV-associated endocervical adenocarcinomas, there are abundant apoptotic bodies and mitotic figures, as well as intratumoral and peritumoral neutrophilic infiltrates. So there is a spectrum of histologic patterns in these cases. So the majority of the cases has this insular growth pattern with these solid nests, but we see that significant portion of the cases show the formation of these gland-like structures within the nests as seen here. Some cases showed areas of solid growth, and some cases showed single cell dispersion. Less common morphologic patterns included papillary growth or a micropapillary growth or a trabecular growth pattern, as shown here. And the appearance of the cells also varied. Some cases showed eosinophilic cytoplasm, some cases showed cytoplasmic clearing, and some showed the glassy cell-like features with these sharp cytoplasmic margins and the ground glass eosinophilic cytoplasm with prominent nucleoli and infiltrating neutrophils and eosinophils. Histiocytoid features and signet ring cell-like features were also seen. And other features included bizarre nuclear atypia, mucin pools, and these hyaline-like globules, as well as squamoid differentiation. And the mixed cases, those usually showed distinct and separate from each other. Like here, we have the ISMC component separated from the neuroendocrine component. However, when we look at the junction of the two tumors here on the bottom, we can see an intermixing of each component. And on the right, we have an interesting scenario where we have the ISMC here, and on the top we have a precursor lesion. This is a SMILE, and here on the right we have an AIS overlying, both overlying the ISMC. So this is a good example of ISMC with two different precursor lesions. So I showed you a variety of histologic patterns and cytological features that ISMCs can show, and the authors hypothesize that the reason of this could be that ISMC is likely arising from HPV-infected reserve cells that retain their pluripotent ability, and therefore showing varying histology. So all of the cases showed apoptotic bodies, mitotic figures, and variable amounts of mucin. Those findings can also be seen in traditional HPV-associated usual type or mucinous type adenocarcinomas. And the authors state that the morphologic clue is the peripheral nuclear palisade, which is a kind of a specific morphologic feature to ISMCs. They also suggest, I recommend that P40 and P63 immunohistochemistry, which is often expressed in the peripheral cells of the tumor cell nests in ISMC. They also mentioned that P53 are more commonly showing mutation type labeling in ISMC. So some cases showed micropapillary architecture, which would bring the differential of serous carcinoma, likely a metastatic one. For those cases, an HPV testing would be very helpful in differentiating. Some cases showed cytoplasmic clearing, atypical and bizarre nuclei, and hyaline-like globules, which would bring the differential of a clear cell carcinoma. So again, HPV testing would be very helpful for the differentiation. And they also warn us that the HNF-beta staining might not be useful because some portion of ISMCs can show HNF-beta staining as well. Some cases show the glassy cell features and areas of squamate differentiation, which would bring the differential of adenosquamous carcinoma. And for those, ISMC shows frequent MAC6 positivity with only patchy P40 and P63 staining at the periphery of the nest. So there is no actual well-formed squamate differentiation, whereas in adenosquamous carcinoma, the squamous and glandular components are well-formed and distinct. And finally, the nested growth and cytoplasmic clearing can also bring a differential of squamous cell carcinoma. And for those, the presence of intracellular bridges and diffuse P63 or P40 expression would favor squamous cell carcinoma and not ISMC. So prior studies showed that the outcome is worse in ISMC, and this paper also confirms that finding with higher percentage of cases presenting with high stage and silver pattern C invasion. So it is important to recognize the morphologic spectrum of ISMC, as these are potentially aggressive tumors compared with the usual type adenocarcinomas. And the authors also state that to better understand the significance of ISMC morphology with respect to outcomes, additional studies with more detailed data are needed. So in my last slide, I will talk about the strengths and the areas of improvement of the paper. So this is a multi-institutional and international study. So we have a patient population that is diverse, which is a great strength. And we have the authors that are experts in this area who are explaining us the various morphologic patterns of this entity with very good descriptions and beautiful figures. So I believe the paper achieves its original aim. In terms of areas of improvement, the paper does not talk about the HPV status of the cases or the type of HPV detection method, as well as whether if there's a type of HPV that is commonly seen in these cases. Another thing is that immunohistochemistry approach was only discussed in the discussion section, but I would love to see some of the most challenging cases in this study with the IHC results so that we can see how the experts in this area are figuring out these challenging cases. So, and also it would be, I think it would be nice to see the status of P53 in these cases. The clinical significance of the variants, morphologic variants, and the pure versus mixed ISMC is not addressed in the paper, and the authors also already stated this need of improvement themselves. And they actually have a follow-up paper, and they show the presence of ISMC either as a pure or mixed form is associated with bad outcome. And of course, the molecular studies would be really helpful for us to understand the pathogenesis and the reasons for this unfavorable prognosis of this entity. And in terms of the applications, so this paper increases our awareness to the various morphologies of ISMC and help us recognize and initiate further workup for the ISMC component. So it would be very helpful for diagnostic purposes. And with that, I conclude, and thank you very much for listening. I'm ready for questions.
Okay. I will launch the polls now. And they should be on the screen for those watching the video.
Nesli, it's hard to believe you're just a second-year resident. That was a fantastic presentation. Well done.
Thanks so much.
Totally agree. All three presenters today have been really amazing.
Looks like we've got just a few people answering our questions.
Okay, we'll just do a few more seconds and then we'll go over these together. Okay, let's see how we did.
Looks like we did pretty well. So, yeah. Well, maybe not so well. 57% of respondents got the first question correct. Metastases have been reported in these tumours, especially to the lungs, and the remainder of the responses are incorrect. And for the second question, a much better result, 86% got this correct. Most tumours were silver pattern C. They showed stratified cells with no nucleoli, peripheral palisading, infiltration into stroma, and the morphologic diversity is one of the most challenging features. So well done.
All right. Okay. So now we had, it seems like the majority of what's happening in the chat is people are just telling you all that you're wonderful. I concur.
Yeah, I concur as well. I'm really super impressed with the quality of the presentations, the way you managed to tackle a difficult and complex subject and present it so beautifully and efficiently.
Mm-hmm.
So we don't have, same with the hosts, we don't have any specific questions. So I thought, given so much is happening in and changing in gynecological pathology and cervical pathology in particular, that there's a lot of discussion points here. As Vanessa touched on with the advent of molecular testing, we're seeing these newly defined entities emerge with potential for targeted therapy.
Mm-hmm.
And now with HPV vaccine being rolled out worldwide, we're obviously going to see a change in the epidemiology of HPV or of cervical malignancy and precancers, with a relative increase in the prevalence of HPV-independent tumours.
Mm-hmm.
And with the 2020 WHO that was recently published, we've seen a really significant shift in the way we classify precancers and cancers in the cervix, in line with the international classification into HPV-associated and HPV-independent. So there's a lot going on in this particular field. And I thought, in light of all that, it might be interesting for us just collectively to comment on, has everyone started routinely doing HPV testing on malignant cervical lesions? Are you now doing P16 or HPV-ish on SCCs in the cervix? And what HPV detection method do you all use? I'm only able to access P16. We don't have HPV-ish, and HPV molecular is something that's really only done in the domain of research. So I'm curious to know what HPV detection methods you use. Maybe we'll start the ball rolling with that. Particularly curious to know what Vanessa does in the Philippines, if she's still there.
Yeah.
Yeah, so HPV testing and P16 aren't widely available here yet. So I was actually happy to see in the latest WHO that if you don't do the HPV testing, you can still call it, like based on the morphology, especially for the adenocarcinomas. Yeah, because not widely available.
Yeah.
It's so different. P16 is like a reflex test that we order multiple times a day.
Yeah, I was thinking about that, how maybe even, you know, half a generation ago, P16 wasn't a thing. And I think about how often I use it in my daily practice. And so that's primarily what we do. But I would say that most patients who present with squamous cell carcinoma have had a pap smear. And so we have that advantage of having the HPV done on the pap smear. And I sort of use that as a surrogate HPV test of the tissue, because we do not have in situ hybridization. We have to send out for it. And I have some mixed feelings about HPV in situ hybridization. I don't know if you've had any experience with it, but it's really hit or miss. Sometimes it's a great test. It really depends on which test you're using, but it can also be really hard to interpret. So sometimes I find that P16 is the better test because it's more widely available and it's easier to interpret. So
that's really interesting to hear, because I feel like we're missing out because we don't have access to HPV-ish, and I'm reading that it's a superior test and a gold standard.
I think the RNA-ishes are really good, but those are sort of being brought online. And I think a lot of that is being driven by the head and neck folks, because their clinical algorithms call for a lot of times like co-testing with P16 and HPV. So I think that's an area where it's really exciting, but I don't think that a lot of institutions have that RNA-ish kind of online yet. I think maybe 10 years from now, it'll be a different story though. So that's really an interesting question to think about for sure.
And what about you, Nesli, in San Francisco? Do you have RNA-ish?
Yeah, we do have RNA-ish, but like you are, we also, most of the time for cervix, we do P16 because the correlation is very good. And for HPV-ish, usually we use it like for other tumors that, you know, P16 that does not correlate with HPV status.
Yeah. Okay. Yeah. And what about doing P16 or HPV-ish routinely on an SCC of the cervix? Is that something people are starting to do?
I'm not sure.
I don't know if I'm going to out myself as not following the WHO. And like this is being recorded. But I would say that if someone has a precursor lesion and has an established HPV history, and especially if it's in the same tissue, I probably wouldn't necessarily do it.
Yeah. Likewise, I agree.
I agree.
But I think where it's really helpful are these glandular lesions, which we sort of, you know, touched on a little bit with the presentations, but it gets much trickier in the arena. Then I would say yes, definitely.
Yeah, absolutely. And the other thing I was interested in hearing was cervical screening. What sort of cervical screening programs are the norm in your hometowns, in your countries? I'm guessing the Philippines is quite different to the other two of us, the USA and Australia.
Yeah, so majority of our pap smears are still conventional pap smears. And although liquid-based has recently been offered in some of the bigger hospitals in the main cities, but most are still conventional. And we do have the guidelines, but compliance with the guidelines and encouraging patients to do the routine screening is still an area where a lot of improvement can be done and put in place. So we get a lot of cervical cancers cases that are far advanced. We don't really pick as much up on screening.
Yeah.
Wow. And in the US, I understand that you've now implemented HPV testing as your first point of test or triage for whether or not the patient goes on to cytology.
This is quite controversial, actually, in the United States right now. I don't, Nestle, you're nodding along. Do you want to comment as well? But I would say this is an area of controversy among pathologists, cytopathologists, clinicians. Where I am, I think people are not using primary HPV screening yet. We're still doing co-testing. So I think that's the algorithm, and it depends which guidelines you're following. I think some institutions are starting to offer HPV screening as a primary, but you also have to have a specific test to do that, which you know very well from what you're doing. But I would say it's still pretty controversial. I still routinely get pap smears that do not have HPV ordered on them in patients where it should be ordered. So I think there's still a pretty big spectrum. What do you think, Nestle? You're nodding along. So
I think we're doing the same thing. Yeah, it's usually they do co-testing, and sometimes I see that HPV test is not even done.
yeah.
So yeah, and yeah, depending on
because,
yeah, go ahead.
I was going to ask, what's the reason? Is there skepticism over the transition to a different test?
I think, honestly, I think it's some clinicians who were maybe practicing before HPV co-testing was a common practice, either don't incorporate that into their practice, or they just, like, the ordering interface is confusing. I'm sure there's a lot of reasons, but sometimes I wish as a pathologist, I was allowed to just order it because it would be helpful, but
it would absolutely. Yep.
Yeah.
Well, that's really interesting.
Yeah.
We implemented a renewal to our cervical screening program in 2017. And so our primary test is an HPV test starting at the age of 25 and 5 yearly thereafter if your HPV comes back as negative, based on the fact that it has superior sensitivity for detection compared with conventional or liquid-based cytology. And we had some dramas implementing the change, but it's generally, I think now it's running smoothly and people have embraced it. We only look at cytology as a reflex if there's an oncogenic HPV detected.
Right. That's so interesting to me. And I know you and I have talked about this before, Karen, but also like the idea that Australians sort of like joined together and did this cooperatively, and there's just like this sense of like everyone's kind of in it together, and how that can only happen, it's happening, I think, in Sweden, but like it just has to be like, I think it's going to be more difficult to implement in some countries compared to where you are.
Yeah, absolutely. And I think the same is true of HPV vaccine as well. We've got uptake rates approaching maybe even beyond 80%. It's now part of our standard HPV vaccination schedule. It's given at school-age children, 13 years of age, boys and girls. And I'm sure that the story is very different in the US and in the Philippines.
Yeah, it really depends where you live. Some states, I think where I live approaches the level of Australia, but there are some states where it's not so high.
Still a lot of work to do, isn't there?
Yes. And I remember when the HPV vaccine came out, people were saying like, cervical cancer is just going to go away. And it turns out it's a little more complicated than that. So
yeah. And people are saying the same thing about COVID, weren't they? Yeah.
No. Anyway, well, I don't know, does anyone else have any closing comments or anything before we go? No.
I guess I'd just like to thank the presenters for being so willing to take on these tricky subjects. Some of these entities are uncommon, a bit esoteric, so thank you for being so willing to participate and to tackle some difficult literature on emerging entities, and to do it with such finesse. Well done to all of you.
Yeah, and thank you to Karen for being the Eastern Hemisphere, which still sounds weird in my mouth because people don't talk about that, but it makes more sense for time zones. So I'm just going to try to make it a thing. But thank you for doing this, and thank you for everyone who joined, and please spread the word, because ISGyP is trying to be more inclusive in time zones and making this live for trainees in other parts of the globe. So thank you all so much. Okay.
Thanks for having us.
Yeah, thank you.
Pleasure.
Thank you very much.
Thank you.
Thanks,
Thank you.
everyone. Bye.
Thank you. Bye.